Hello, and thank you for joining us for this month's Anticoagulation Forum webinar. In collaboration with the Foundation for Women and Girls with Blood Disorders, we present a webinar on women's health considerations in thrombosis. I'm very excited. We're going to take a case-based approach, presenting a single patient through various stages, first with contraception and VTE risk, and then menstrual bleeding with anticoagulation, and then pregnancy. And so I'd like to introduce our speakers for you. My name is Naomi Yates. I am a pharmacist manager for clinical pharmacy services at Kaiser Permanente, Georgia. We'll be welcoming also Dr. Sara Vazquez, clinical pharmacist with University of Utah Health Thrombosis Service, as well as Dr. Bethany Samuelson Bannow, an associate professor of medicine at the Oregon Health and Science University, and Dr. Jori May, assistant professor of medicine at the University of Alabama at Birmingham. At this point, I will transition to Bethany. She's going to share a little bit more with us about the Foundation for Women and Girls, and then we'll jump into our case.
Thank you so much. And FWGBD is delighted to partner with AC Forum on this webinar. The Foundation for Women and Girls with Blood Disorders offers a variety of resources for the healthcare team. On fwgbd.com, you can find the Women and Girls Clinic Directory, which shares information about availability and range of services specifically devoted to the care of women and girls with blood disorders. We also have a podcast, the 721, which is a conversation-style podcast, much like today's webinar, that answers the most pressing questions about periods and heavy menstrual bleeding. Also consider joining FWGBD through membership opportunities available for physicians, students, and partners. And next slide, please. And one of my favorite meetings every other year, as it is the FWGBD conference, which we will be having this year, September 13th through 15th in Long Beach, California. This is in addition to our virtual education programs, which I mentioned earlier. So more information and registration is available at fwgbd.org, and I hope to see many of you there. Thank you.
Well, Bethany, maybe we'll just go ahead and dive in and start talking about some cases together, and with Naomi and Sara as well. So as Naomi mentioned, we're going to be talking about kind of a single person as she's going through her life and encountering challenges in thrombosis and hemostasis. So this is a common patient that we see in our practice. A 23-year-old female comes in with a new proximal deep vein thrombosis, or DVT. So she had been started on a 4th generation combined oral contraceptive about 6 months ago. And we're going to get into some of that terminology in a minute. But she asks you as a provider, is this combined oral contraceptive the reason that I developed a DVT? Next slide. So, when we think about contraception options and VTE risk, the question that we often find ourselves asking is, so what is actually the VTE risk with our different contraceptive methods? Because there's a lot of different things out there. And I think there's some misconceptions that, well, all contraception comes with a blood clotting risk, but there's actually a lot more nuance to that. So if we can go to the next slide, there's a big table that I'm going to take you through. And so the way that we think about contraceptive options in thrombosis is basically what is the medications that are contained within it, or do they contain estrogen, do they contain a progesterone, or do they contain both? And so you'll see here that there's a variation in risk based on the contents of these different methods and the way that they're delivered. So I just want to start to orient you to what we're looking at. So in the top columns, the rows, see we have our hormone preparations, the progesterone component, the estrogen component, the effectiveness for contraception, and then some numbers about the VTE risk. And I want you to look at the color coding here, that our highest risk options for contraception are listed at the bottom in red, and our lowest are up here in green, kind of with some gradation here in the middle. So what are those things that we know do not come with a blood clotting risk in people that do need a contraceptive option? Those are our progesterone only options. So we see our progestin only pills, our progestin-based IUDs, and the implant that is used under the skin. I will add that the implant Some has a warning from the FDA about thrombotic risk. The data does not necessarily support that. So this is considered something that is safe and effective for people with a thrombotic risk history. And if you have a patient that develops thrombosis, we wouldn't blame these agents. You'll notice a kind of transition to yellow for the injectable progesterones, depot. It does seem that those have a somewhat increased risk of thrombosis. So you see here an odds ratio that's reported of about 2.2 increased thrombotic risk. So maybe not as high as some of the ones we're going to get to later, but is one in someone that has had thrombosis that we try to avoid if possible. Now we're going to get into some of these other that contain both estrogen and progesterone, so those combined options. And you see here we've got different delivery methods. We have our vaginal ring, we have transdermal patches, and then we have our oral contraceptives that are listed in different generations. Important that they're, when we think about why we have thrombotic risk with our contraceptive methods, it's really based in the estrogen. And so the way that the estrogen is kind of process and activates the production of clotting factors from the liver. And so how that estrogen is metabolized and how it affects the liver does increase the clotting risk. So those oral preparations actually are thought to have a higher risk because they have that kind of initial metabolism through the liver and they increase clotting factors. The progesterone component, like we talked about, when it's by itself, does not necessarily increase thrombotic risk, but is thought to really kind of regulate how the estrogen effect happens. And so there is some influence of kind of the thrombotic risk based on the progesterone component that's used as well. So in general, we see in the vaginal rings and transdermal patches, and then these what we call first and second generation progesterones that are listed here are thought to have kind of a intermediate thrombotic risk, so do come with a risk, but are maybe lower than what we call our third and fourth generation progesterones. So some of the newer components that we see in newer birth control formulations that may have a higher thrombotic risk. You see here odds ratios closer to 3 or 4. So I think the kind of general take home in a patient like this who was taking a fourth generation combined oral contraceptive, this is a method of contraception that is associated with a higher thrombotic risk. So that was a lot of information. And Bethany, I wonder, is there anything other pearls that you feel like I missed, or when you're thinking about contraception and BTE risks, other things that come to mind in the conversation?
No, I think that's a really great summary, Jori. I agree with everything you said. When I think about this practically, I kind of break it down into two categories, right? There's the green and then there's everything else. So whether or not somebody was on a fourth generation versus a second generation, I don't think really makes a difference in the things like risk of recurrence and things like that. I think it's also really important when we're looking at these, odds ratios to keep in mind that this is, maybe 2 to 4-fold times a risk of like 1 to 2 in 10,000, right? So even when we double that number, it's still very low. And importantly, all of these numbers are lower than the risk of VTE in pregnancy. So it's really important to keep in mind the benefits as well as the risks.
Those are excellent points. And I think, again, not that we shouldn't be using these, they are definitely important, but being aware of their thrombotic risk and then, being able to counsel people that that risk is there, but it is a small risk in general. Great. All right, next slide. So we've kind of answered that question, and I want to go into some other questions that come up surrounding this case. So let's think about what are other factors that affect VTE risk in patients that are using particularly the combined oral contraceptives that contain estrogen and progesterone. There is data to suggest that there are other things that when in combination with those combined oral contraceptives kind of even more increase the risk. And those are things like obesity. So in general, a BMI over 30 to 35 in combination with an estrogen and progesterone medication really increases that risk. Tobacco use is another one. So smoking, we strongly advise against in people who are taking these medications. And then we think about our other traditional risk factors for VTE. So people who are having surgery, people who are in the hospital, other things that are happening in that patient are important to think about rather than just saying, oh, this person was on birth control, that's the reason that this happened. But having a broader perspective and understanding that oftentimes I kind of almost think about it like a stacking of factors. And so maybe the combined oral contraception was part of the issue, but what are the other risk factors that kind of stacked up and ultimately tipped that patient over to develop a blood clot? So thinking about that, I think, is really important. Bethany, are there other things that you think about specific to this population when you're kind of assessing VTE risk to try and figure out what could have caused this?
Yeah, I think you really hit on all of the highlights. Yeah, and I think, screening for sort of traditional risk factors is something we maybe sometimes forget, and something we can focus on more, like you've highlighted. I think about patients with inflammatory bowel disease or maybe nephrotic syndrome or things like that, which are very low rates in general population, maybe a little bit higher in my clinic for obvious reasons, but it's important not to forget those aspects and
Yeah.
whether or not those are reversible, right?
Absolutely. Because then that leads us to our next question of then, how long should a patient be anticoagulated? So the question of in a patient with a VTE who's taking a combined oral contraception, how long should they be on a blood thinner? Is this something that's considered a reversible risk factor? So if we're ultimately able to come off it, they can stop anticoagulation or not. And I think that this is kind of an area of debate and tends to fluctuate. In my practice, in general, the things that I think about that make me say, this was a blood clot related to this medication, and therefore I feel comfortable if we have a plan to come off it to stop after 3 months. Things that I think about are, the time of initiation. So there is some data to suggest that those folks that are, that high risk period for starting a combined oral contraception is that first year. So if they develop, like our patient who developed a blood clot within 6 months of starting the medication, it makes me feel more confident that maybe it's related to that medication, as opposed to someone who's been living and doing just fine for 5 years, 6 years on this medication without an event. Other things I do sometimes think about is, the thrombotic risk based on that table that we discussed, maybe a fourth generation as opposed to, the depot injections. That risk is there, but there is some variation in kind of the strength of risk that comes with those different medications. I think the other things that I think about is, well, are there ways that we can further risk stratify? So there's some data from the Dodd study that I often use of talking about a D-dimer for risk stratification in people that are on these medications as well. So I think it's not always a clear slam dunk if this is, they were on a combined oral contraceptive that if they come off, you can absolutely stop anticoagulation. I think there is some nuance there. Bethany, how does that work in your practice?
Yeah, I agree. There is some nuance. I think, historically, for this general population, the data has really been supportive of a very low risk of recurrence. So I agree, it's not an absolute. In fact, I just had a patient in my clinic last week who had been on, birth control for like 10 years and something happened. It was like, I don't think we can just say this is the birth control, right? But I think in general, I do lean towards being able to get these folks off. That said, when I do that, I think it's critical to have some important counseling around what are other high risk scenarios, talking about like you will need a blood thinner to prevent clots during pregnancy in the future, which we're going to talk about, right? I have conversations about like the risk of HRT. And always let your doctors know if you're in the hospital, let me know if you're going to have a surgery, things like that. So I think, making sure that we discuss that other high risk time periods can come up is an important part of that counseling.
Absolutely. I think that's so important. And in that conversation, oftentimes this last question comes up too of, do patients with estrogen associated VTE need to be tested for inherited thrombophilias? And, the American Society of Hematology has recently released some guidelines that have influenced this conversation. And I think it's an area of a lot of debate where, it's kind of unclear what the right thing to do is. So the new ASH guidelines that came out do recommend testing for inherited thrombophilia in people with estrogen associated VTE, and that's part of the decision making for those if those people should be continued on anticoagulation or not. I think there's a lot of debate within the hematology community about that recommendation. It is a weak recommendation. It was based on some modeling, and so a lot of hematologists say, well, what Bethany's mentioned before, the risk of recurrence is really low in this population. Some of these inherited thrombophilias, particularly those like factor V Leiden heterozygosity or prothrombin heterozygosity, may not have a very high increased risk of recurrence either. So it's something that in my practice, I don't necessarily do for everyone. I think starting with a really thorough family history. So particularly, if there's someone with a strong family history where I think testing might kind of change their management or change things for their family, that's a person that I might think about testing. Or people where, they are very young age. This is kind of their first thrombotic challenge. And I'm concerned that they could have one of those stronger thrombophilias like protein C deficiency, protein S deficiency, or antithrombin deficiency. Maybe that's someone I would be more inclined to test. But I will say in my practice, there are people who don't have a strong family history. They had a VTE early after starting a prothrombotic medication, and I don't feel strongly that testing for an inherited thrombophilia influences my management. I know this is a hot topic, so I'd love to get your thoughts, Bethany, on what you do in your practice and how you've kind of incorporated this recommendation or parts of it.
Yeah, that's tough. It's a little bit of a moving target. I believe that information is power and that shared decision making is key. So I am just extremely straightforward with my patients. And I say, historically, I would not have recommended this. This recommendation is really based on the idea that if we continue anticoagulation in those with a thrombophilia and stop it on those without, we will prevent more blood clots than the number of blood clots we prevent essentially outweighs the number of major bleeds that we would create. It's a very rough approximation of it. But it doesn't take into consideration things like risk of heavy menstrual bleeding, which I know you're going to get into later, Jori. It doesn't take into consideration like what does it mean for a patient to be on a blood thinner indefinitely when the benefit is really probably pretty small. And so I'm just very straightforward about all of that. I think, and the authors of the ASH guidelines were very clear too on the limitations of the evidence and their recommendations. They did not come out and say this must be done. But I also know that patients go and get information in a variety of different ways. And, I don't want there ever to be a scenario where they're wondering why I, as their doctor, didn't talk to them about this. So that's my approach. And if they say they want it, I offer it, but
yeah, absolutely.
I mean, and
I think it's a conversation too of like what to expect with the results, right? Because I think that's often the challenge too is, sending testing and not really, what are we going to do if it comes back and you're heterozygous for factor V Leiden? Like, are we going to be comfortable saying that you're going to continue? And so having, a conversation, I think, about that guidance, and then also about what are we going to do with any information that we get is so important. And I love that you've highlighted that. Great. All right.
A few questions that were sent in ahead of time. Is it okay if I jump in at this point?
Oh, yeah.
Yeah. So the first question you guys kind of touched on a little bit is what type of contraception would be best for a female on anticoagulant medications? Do we use the table? Do we talk about other risks and try to risk stratify? How do we go about that shared conversation with the patient?
Yeah. So the question I get, for a patient who's taking anticoagulation, like maybe that's how we'll interpret it. Yeah.
So that they're already taking anticoagulation, they want contraception. How do we go about that conversation? Yes.
Got it. And yeah. So, in those folks, again, we kind of talked about the different risks. So in general, if we can find a progesterone only option for that patient, it's great, right? And so particularly in a patient on anticoagulation, usually we're dealing with issues of heavy menstrual bleeding. I'm a big fan of the progesterone IUDs because those decrease menstrual bleeding and also offer contraception. We'll talk a little bit about the available information that suggests if a patient really needs to be on an estrogen containing medication, that they can do that safely while they are anticoagulated. So that option is there, but oftentimes I feel like I'm able to comfortably find a progesterone only option for my patients that have a VTE history and are anticoagulated.
Thank you. And what are your thoughts regarding the safety of HRT in women with increased thrombosis risk?
Well, so HRT is usually a different form of estrogen. Is kind of that estradiol, a naturally occurring estrogen, and in general is thought to have a slightly lower thrombotic risk compared to the combined oral contraceptives. That being said, kind of to Bethany's point, from a practical standpoint, we still consider that to be a risk of those medications. But in people that are really trying to decrease that risk, there's also some data to suggest that the transdermal form of hormone replacement therapy actually also is lower risk than, say, an oral preparation. So there are ways to try to decrease that risk and still receive estrogen for, hormonal replacement therapy. But, practically it is still a risk of any formulation.
I will add, I think one potential exception to that risk is vaginal estrogen. I think it's really important, and that can be life-saving, right? In elderly patients, postmenopausal with recurrent UTIs, I told them they can always have vaginal estrogen. I will never say no to that. And I tend to, yeah, again, it's back to shared decision making. I do tend to lean on the side of letting folks be on transdermal estrogen. Really, if nothing else works, like the lowest dose for the shortest time possible is sort of a general rule. But I think we do a lot of withholding of treatment from women because the people in power have not experienced what it's like to not have those treatments available. And so I try to be really cognizant of that, in addition to being very straightforward about the risks of all of these things.
That's a great point.
As a follow-up to that, would you feel comfortable with transdermal estrogen if they were not on long-term anticoagulation?
I do that sometimes, yeah. Again, with a very frank discussion, like we don't have super great evidence. The evidence we have suggests that it's a different form of estrogen. We are not dealing with first pass effect. It's a much lower dose than oral contraceptives. Like there's a million reasons to say this is lower dose. That, I mean, if they had a blood clot, like while they were like on a 2-hour flight and we're treating that as their provoking factor, that I feel like is a little bit different. Personally, I would probably have that person on long-term anticoagulation, but I do make it an option, and it really comes down to the patient, right? Like they're the ones who have to live in their body. They have to deal with like what the risk of the VTE is versus not being able to function because they're having these like terrible hot flashes that are interfering with everything. Or certainly I have some folks who have like premature ovarian insufficiency. For those folks, it's really hard. So I think we have to keep all these things in mind.
And I think you pointed out too, just being careful about the fact that the type of VTE matters, right? So, if I have a patient who had no presenting symptoms, came in with a massive PE and required ECMO, that's someone that I'm going to feel a lot less comfortable being looser with estrogen than somebody who maybe had a small DVT in the setting of some weak provoking factors. And so I think that that's also part of that conversation in relation. So it's not only the estrogen, but really, those details of the patient that are so important too. Great. Well, should we move on to the next section so we can keep going in discussion? So we'll do the next slide. So we'll say that this patient, when she developed her lower extremity symptoms of DVT, she came to the emergency department for evaluation. And so at that time, she had the ultrasound, it identified the DVT, and she received the following recommendations. She was told to fill a prescription for a direct oral anticoagulant starter pack. She was told to stop her combined oral contraceptive and follow up with her primary care doctor. And that's a pretty common experience for, what a patient, the care that somebody would receive with a new DVT, seeing an emergency department provider. But I think that there are a lot of points for discussion within this case as well. So next slide. So first, let's talk about what is heavy menstrual bleeding and how do we talk about it with our patients. I think the challenge that we know kind of throughout the healthcare literature and throughout kind of the lived experience of people with heavy menstrual bleeding is that it's something that we don't talk about in general, right? It's not part of kind of our comfortable daily language. There's a lot of emotion. There's a lot of potential shame associated with menstrual bleeding that's historical and related to a lot of things that people that menstruate experience through their lifetime. And so in general, there's data to suggest that we just don't really talk about it. So what is heavy menstrual bleeding? I'll go to the next slide. So Bethany made reference to the 721 part of the Foundation for Women and Girls with Blood Disorder podcast, which I highlight here in the bottom right. But this is a little educational graphic. I think it's helpful for providers, but also for patients to understand like what is a heavy period. And so the 721 rule helps to describe that. I think it highlights here that 1 in 5 women will experience heavy periods. So this is a very common experience. Many people who menstruate have experienced heavy menstrual bleeding, but they don't necessarily have a name for it or know what it is because they don't compare their menstrual bleeding to anybody else. So it's just theirs. But the questions that we ask people about their period to tell if it's truly heavy is we say 7 is for 7 days. So your period that lasts longer than 7 days or more. If you need to change menstrual protection more often than every 2 hours. And if you're passing blood clots, the size, I changed it to a quarter because this is European, but blood clots the size of a quarter. Those are all signs that a patient is experiencing heavy menstrual bleeding. And so I think it's what I always talk to my trainees about is a lot of times the question may be posed to the patient of, do you have heavy vaginal bleeding, or do you have heavy periods? And again, they may not know what that is. And so the answer is like, no, my periods are my periods. But it's asking those very directed questions. So do your periods last 7 days or more? How often are you changing pads or tampons or other products? And are you passing clots? If so, how big are they and how often? So being very specific in our questions, I think, is the best way to get the information that we need from our patients in order to take the best care of them. Next slide. So with that said, I think it's not surprising to anyone in this audience that people who have heavy menstrual bleeding and start an anticoagulant, they're going to experience more heavy menstrual bleeding. And then alternatively, people who maybe have not had heavy menstrual bleeding in the past start an anticoagulant and then experience heavy menstrual bleeding. But again, the data suggests that we don't necessarily talk about that frequently in people that we're starting anticoagulation with. So I think that's kind of the first point is, I hope the takeaway from this webinar is that anytime you have a patient that menstruates and you're starting an anticoagulant, that ding, in my mind, I need to talk to that person about their periods. And so the questions that we then run into is, okay, we know that this patient had a VTE. We know this patient needs anticoagulation. So how can we think about their menstrual bleeding in that context? And so one of the first questions that comes up is, did she actually need to stop her combined oral contraceptive at that moment? And I'd like to pose the statement that no, she probably did not. And so, understandably, well-intentioned providers say, well, this caused the blood clot, so we need to stop this in order to make sure that this patient doesn't have a blood clot. But what we know is that available data suggests if a patient is on anticoagulation, continuing to receive that estrogen is safe. Okay, and we know that if we stop combined oral contraceptives in people who do have heavy menstrual bleeding, or in anyone who menstruates, that their menstrual bleeding increases. They get a rebound effect. So we have this patient with VTE, we're starting anticoagulation, we take away what they're using to control their menstrual bleeding and experience rebound. And so often these people will experience extreme heavy menstrual bleeding with their first cycle after a VTE. And so in the patient where there kind of is appropriate discussion and understanding that if you start a combined oral contraceptive, taking that blood, or if you continue your estrogen, continuing your blood thinner is really important. But that we keep those things until we have a plan for what we're going to do long-term with the anticoagulation, with the management of menstrual bleeding for contraception. Because the other concern is that if we stop contraception, that this patient could become pregnant. And we know that kind of the risk of pregnancy in that acute 3-month period after a VTE is very high risk. And so ideally, we counsel patients not to become pregnant within that first 3 months when that acute clot is healing. And so then we're taking away their contraception. That could lead to some potential problems. So I see a lot of head nodding. So I'd love to hear, with Bethany or Naomi, thoughts on this and how you feel about this in your practice.
I completely agree. If I had 3 wishes, one of them would be that our ER providers would be educated on the fact that they don't have to stop these. I think this is one of the most harmful things we do in medicine. And while I agree it's well intended, it is ultimately harmful. And I'm thoughtful again about sexism in the way we approach things. Like, if we had men come in and they had, an event and we said, oh, well, I'm going to take away this medication that could prevent something from you, it could prevent you from dying, from a bad thing happening that could lead you to dying. Just don't have sex for 3 months. Like, that's a little bit blunt, but we would never say that to men. Let's be honest, right? That would not happen. And if there's any folks on here from my institution, they're used to me saying the alternative to birth control is not nothing. It's pregnancy, right? And this is something that we tend to think like, oh, this is just like a fluffy medicine that doesn't really impact health. It absolutely does impact health. And I think we need to be really mindful of that.
That's a great point. Absolutely. Well, and Naomi, other thoughts on that?
I was just going to say the questions that were sent in, you guys have hit on. People were asking about counseling points, about when should the hormone be discontinued. So I know we're a little short on time. I don't know if we have anything else coming in the Q&A, Sarah, if we want to go ahead and jump into the next case.
I think we can go ahead.
Okay.
Yeah. Well, maybe do the next question, because I think it's an important one and we can cover it quick, of what options do we have to manage menstrual bleeding in people that are taking anticoagulants. So, we know even, if we talked about estrogen, right? So this person was on birth control, potentially continuing that until we have another method, ideally, a progesterone only method or something like that, so is a really essential part of this. Other things that we think about is understanding, are there other contributors to menstrual bleeding? So we know it's not just hematologic. So partnering with our OBGYN colleagues to think about, are there structural or other hormonal issues that are at play that are influencing this patient's bleeding? And so in an ideal world, something that the Foundation for Women and Girls with Blood Disorders works for and advocates for, or that coordinated care, or multidisciplinary clinics where a patient can speak with a hematologist and speak with an OBGYN to make sure we're considering those other causes of menstrual bleeding. Another medicine that tends to come up in this conversation is tranexamic acid. So there, again, here is some misconceptions and often some lore and concern that tranexamic acid can cause thrombosis. We have kind of robust data at this point in different settings, including the postpartum period and trauma patients, where we, use tranexamic acid without that increased risk. So in general, this is thought, it's an antifibrinolytic agent. It prevents fibrinolysis or breakdown of clots, but not necessarily causing them to happen. So it is, in a patient who's on anticoagulation with a VTE history, I do feel comfortable using tranexamic acid for menstrual bleeding control. That being said, and I have learned this from reading from Bethany's recent paper that we'll highlight, but that ideally we maybe wait a period of time, because do you need some of that healthy fibrinolysis in order to break down the clot that's happened potentially? So maybe it's not my first agent that I go to in the first few months after a VTE event, but it's something that can be really helpful for long-term management of menstrual bleeding. There's questions too about different anticoagulants. Are some anticoagulants more likely to cause heavy menstrual bleeding than others? The available data that we have suggests that rivaroxaban may have a higher risk of increased menstrual bleeding. And the thought there is that maybe because it's dosed daily rather than every other day, it has those higher peaks. And so maybe people may have more bleeding because of that. So dabigatran is one that maybe has the lowest risk. Some Eliquis or Apixaban, also potentially could have a lower risk. So if I do have somebody on rivaroxaban, sometimes I do think about changing the agent. And the other thing to think about is in the long term, we have data on dose reductions for rivaroxaban and apixaban after 6 months, where we cut the dose in half for VTE prevention. And so I'll often do that in people that are having heavy menstrual bleeding. Things to be cautious about, though, is interruption of anticoagulation for menstrual bleeding, particularly in that acute period. That's something, again, in shared decision making, if that's not, to venture into carefully with patients. But I think that hopefully we have other ways to control their menstrual bleeding without having to interrupt anticoagulation. So kind of a whole list of different ways that we can kind of creatively work with our patients to think about controlling their bleeding. Any other thoughts, things I missed on that?
No, I think you really hit the nail on the head there. And there will be some interesting data coming out soon from the Medea study, which was done in the Netherlands. Should be published any day now. They unfortunately were not able to complete enrollment, but they did have some interesting findings. And I mean, I will say, to your point on mentioning the tranexamic acid, which was one of the studies one of the interventions they studied, I feel like it kind of depends. Like, that patient you mentioned, like if they come in with a VTE and they're on ECMO, like I want them to have like 3 to 6 months to do as much fibrinolysis as possible, right? But if they just come in with like a distal DVT or something like that, and I decide I have to treat for whatever reason, then I would feel comfortable starting it sooner. And the only reason in my mind not to start it immediately is just that you want that fibrinolysis to happen. We don't really know what impact that would have on like post-thrombotic syndrome, like if people need to be forming other vessels and things like that. So I do keep that in mind, but I think it can be a pretty effective treatment in this population.
That's great. So we'll go to the next slide. And again, just highlight this great paper from Bethany that I added on here without her permission. But I wanted to highlight that it's just if you have questions about the management of abnormal uterine bleeding and anticoagulation, this was recently published in JTH, and I encourage you to check it out.
Thank you for that. All right. So we are moving on to stage 3. And this is a lot of these questions come from another paper that we that FWGBD put out discussing a toolkit for managing these patients. So there's a lot of information and guidelines out there from ASH and ACOG and other organizations about medically how to treat these patients. And I think this case is going to be fairly straightforward in terms of medically how they could be treated. And so I want to focus a little bit on, how do we pull in other team members, like who needs to be involved in this care, things like that, because that goes to some extent to anticoagulation stewardship, which is what AAC Forum is all about. So imagine, if you will, back to our patient. She's 27 years old. It's 2 years down the line. She did her 3 months of anticoagulation. We'll just say she was negative for thrombophilia for argument's sake. She's been on the levonorgestrel IUD for contraception, which is amazing for contraception, amazing for menstrual bleeding control. But she is ready to get pregnant. She wants to start a family, right? And so she comes in for preconception counseling, which is my favorite appointment ever. Can I see the next slide, please? So what is preconception counseling? First of all, it's, as it suggests, a conversation that you have about pregnancy before the patient conceives. And so, one of the things that we really address is, like, who should we be offering preconception counseling to, right? Like, when is this appropriate? And in our paper, we really alluded to, I think we need to prioritize folks who have had a blood clot in the past, whether they are on long-term anticoagulation or they came off. Certainly pregnancy will change all of that, right? What anticoagulant they can be on, whether or not they can be off an anticoagulant. So I think those folks are important. I think folks with potentially with a known increased risk factor for VTE. So a lot of times that comes down to folks with known thrombophilia or a family history of VTE. Certainly there's a million other reasons for preconception counseling outside of the thrombosis world, but I think those are kind of the most important folks to make sure we get in. Jori, do you have any other populations you think are really important to get preconception counseling for?
No, I think that's great. And I will just highlight, I think the challenge, as a hematologist is that getting these people to us or to the right person, sometimes it doesn't happen in the preconception phase. So I think what you mentioned is, like, if you have somebody who has a VTE, like before they get released into the world, almost doing some preconception counseling in anticipation of what might come is also really important, because sometimes our system fails us and we don't necessarily get the opportunity to see people before conception.
I totally agree with that. And I would say not only is that an essential part of the discussion, but I also make sure, when I see a patient for VTE, they're done with their 3 months, they're out into the world, I put all of this in my note so they can come back to it. Like, this patient should consider anticoagulation when they get pregnant. Here are my thoughts about HRT, vaginal estrogen, things like that. And then they look at you funny because sometimes they're 21 and this is the farthest thing from their mind, but they might not get this information somewhere else. So thank you, Jori, for pointing out that's a key moment of intervention. And so another question that we addressed are, what are the important components of preconception counseling and when should it happen? So as Jori touched on, at the time, maybe not at the time of diagnosis, that can be a little tough, but when we as hematologists are seeing these folks, it's usually not the time of diagnosis, right? It's usually a couple months out, 3 months out, we're being asked to decide on long-term anticoagulation. That's a great time to have this conversation. I would say annually, if we're seeing patients annually, and this is where our anticoagulation clinic partners are really essential, right? Because they may be seeing the patients more frequently than we are. And so I think just sort of bringing it up, making sure it's in the mind of folks who are on long-term anticoagulation. I also think it's really important to, make sure that we are, again, emphasizing shared decision-making, right? And making sure we're empowering our patients with all of this information. And so things that I talk about are, their individual risk of thrombosis with pregnancy, adverse effects of anticoagulation during pregnancy, after pregnancy, could it impact their lochia postpartum? Talk about choice of anticoagulant. What anticoagulant can you be on when you're pregnant? There's only one. Well, there's different variations of low molecular weight heparin, but it's really just low molecular weight heparin, right? We talk about when to initiate it, especially in a patient who's not on anticoagulation long-term, right? Or in those folks, when do we switch over? Always make sure I'm emphasizing a discussion about signs and symptoms of VTE and when to seek medical attention. Anything else that you include, Jori, that we should emphasize?
I don't think so. I think that really covers it, but it's, again, I think those questions, and I'm interested. So, if you have somebody who's off anticoagulation You know, do you tell them, do you want them on prophylaxis when they're trying to get pregnant? Do you tell them, hey, call me when you have your first positive pregnancy test? Because I think some of those nuances are really helpful to clarify at this visit too.
I totally agree. I usually don't have folks start when they're trying to get pregnant,
Mhm.
right? Because that can take years. And I don't love people being on Lovenox for years outside the setting of pregnancy. I worry about osteoporosis and things like that. And if a patient is having this conversation with me, it means they're probably like one of those folks who are like taking the pregnancy set. They like know when they ovulated and they're taking that pregnancy test on day 10. So they're pretty like, I don't worry about these folks getting like to be 3 months without me knowing, right? And so I usually don't start it in advance. I think a really interesting and important question, though, is do you start it at the first positive pregnancy test or do you start it after the ultrasound? And so our gynecology colleagues, understandably, they kind of like the ultrasound sometimes, right? Because we're making sure that we don't have an ectopic pregnancy. You know, if there's like an early miscarriage, we could be worsening bleeding. I sort of lean on the side of like at that first positive pregnancy test because we know that the risk is up during all of pregnancy, right? I mean, logically, we think it's higher in the 3rd trimester, and some data suggest that, but there's also plenty of other data that don't suggest that. So I don't know if you have thoughts on that, Jori.
I'm kind of with you. And again, maybe it is the difference between our distal DVT patient and our ECMO PTE patient. But I tend to counsel, you know, you call your family when you have your first positive pregnancy test, and then you call me. Is how I tend to phrase it. Just because, again, I have that concern of optimizing as soon as possible.
Totally agree. All right, can we have the next slide, please? And so the next question, so I'm going to talk a little bit about antepartum management here before we kind of extend the case, but I think probably most of us would agree a patient with a history of, CHC associated VTE, they're going to need to be on Lovenox during pregnancy or enoxaparin or dalteparin or whatever your low molecular heparin of choice. That's pretty clear in the guidelines. So then the question becomes who should prescribe the anticoagulation? And this is I think it's a little bit of a challenging question. So I'll go ahead and say what I do in my practice with the caveat that I am very fortunate to I have almost been adopted into my OB-GYN department here. So I'm like work with folks who like really are passionate about this and they're really comfortable with prescribing anticoagulation and not every gynecologist or obstetrician is gonna be comfortable with that, right? But I typically leave it to my colleagues in OB with the reason for that being there's a lot of doctor's appointments when you're pregnant, like a lot. And I don't like to say like, oh, you need to come see me too when your OB who's seeing you like every couple of weeks towards the end there can really prescribe it. And I also think like OBs they like know everything that's going on with the patient, right? They know if there's a subchorionic hematoma, they know if there's been epistaxis, they know all this stuff that I may not necessarily know as much. So that's been my practice. I don't know what your thoughts are on that, Jori.
Yeah, that's been my practice too. Again, I'm at a large academic medical center, and so I have the opportunity to work with OBGYNs that are comfortable with that. I will highlight though that there are some nuance in how hematologists tend to think about anticoagulation and how OBGYNs do. And I'm sure pharmacy may find themselves frequently in the middle of some of these conversations, but particularly when I think about like therapeutic doses of low molecular weight heparin, my OBGYN colleagues here like to monitor anti-10A levels. Our hematology guidance does not recommend that. So it is really important, I find, to have a conversation with whoever you're working with directly rather than going through the patient, because I've encountered situations where the patient is saying, well, my OBGYN is telling me this and my hematologist is telling me this. And it's hard because we were maybe operating from different guidelines. So really trying to get together with that person who's in charge, right? Who's prescribing it? How are we monitoring it? How are we making decisions so that all of those, so we communicate a clear plan to the patient to really make sure that we have kind of their confidence in at this really, delicate time for them.
I think that's a great point. And I know that's going to be a question that comes up about anti-10A monitoring. So I'll just go ahead and say that I don't do it routinely. I consider it in folks who've had a recurrent blood clot on anticoagulation. I consider it in folks with like maybe altered kidney function where it's a little borderline, we're a little bit worried about it. I think about it in extremes of weight. I wouldn't say I do that as much. I think more and more data are coming out that is maybe less of an issue than we initially feared it would be. But those are kind of the scenarios that I think about it in. Jori, do you have any other situations where you really want to do it?
No, I'm the same way. I really kind of stick with that weight-based dosing. I think if you're doing that though, remembering that weight does change so frequently during pregnancy, it's another thing to pay attention to. And another thing to your point, Bethany, of it's nice when the OBGYNs will kind of take charge of that just because those changes are happening frequently.
And I think one of the downsides of anti-10A monitoring, in my experience anyway, is it's not just weight that goes up in pregnancy, it's renal function. So renal function gets a huge push, right? And so these levels often do come back low. We don't have data that says that actually increases the risk. And then I see patients sometimes going home on that same dose as their renal function's diving and their weight is diving, and I get really scared about their postpartum bleeding. So I think, that's a downside that we don't often talk about when we talk about anti-10A monitoring. And so in our time is running short. So I think we've sort of already addressed how frequently should patients be seen by the provider. They're seeing their OB super frequently. I think that's generally enough. So can we move to the next slide, please? Thank you. All right, so back to our patient. Again, fairly straightforward. They should have been on low molecular weight heparin. We will imagine, even though, so the risk of recurrence is going to be really low on this low molecular weight heparin, but things happen. Recurrences happen usually when doses are missed. There's a lot going on in pregnancy. So imagine, if you will, a recurrent DVT happening at 16 weeks. Next slide, please. And so at this point, I think it's good to talk a little bit about delivery planning, right? This is, I see as my main role as a hematologist, is weighing in on this kind of delivery planning. And when do we stop things and who needs to be involved? I tend to think that the optimal timing is probably early in the 3rd trimester. You kind of know what's going on by that standpoint. I don't wait until 36 weeks. Like, who knows, like things happen. And again, we want to talk about things like, when do we stop before, delivery? Is there going to be an induction? Is there going to be a C-section? Are we going to go into spontaneous labor? And what are the implications of that? I always talk about epidurals. And you may have a patient who says, I don't want an epidural. I know I'm not going to want an epidural. I'm like, great. You very well may not. But if your baby is in distress and you need a C-section, you want to be awake for that delivery. So I view it as my job to do everything I can to make an epidural available. And that means having a conversation about this. So I don't know if you have any more thoughts on things that we need to make sure we're touching on in delivery planning, Jori.
No, I completely agree. Yes, there's so much uncertainty. And so you have to have these contingency plans that you said. Even, people will come in and they have their birth plan and they think they know how they want this to go. But I think our job is to make sure that we are ready for whatever ultimately baby decides to do, who's really the one that's in charge.
1000%, totally agree. And I will just quickly, in the interest of time, making sure we have time for questions, kind of lump these last 2 questions together. So I think, who's involved in delivering planning? I think the main point to take away here is the patient. The patient needs to be sort of in charge. I always hope that they understand that they can plan all they want, and it's that things happen the way they will. And I advise people to hold that loosely. But I think making sure the patient is very involved in this conversation, as a hematologist, as a thrombosis expert, if we can be involved, that's great. Obviously the OB. And then another partner that we sometimes need to consider is antepartum anesthesia consultation. Again, because of this question, I don't think that necessarily everybody needs this, like folks who are just on prophylactic low molecular weight heparin, or folks in institutions where there's clear guidelines about, like, okay, you need 12 hours after that last dose of prophylactic Lovenox. They don't necessarily need that, but I also don't want folks to show up in labor and be told, get a surprise that they can't have that epidural they planned on. And so I tend to recommend it for folks on therapeutic anticoagulation. I don't know if you have different thoughts on that, Jori. I would love to hear your take.
Yeah, no, I completely agree. Therapeutic anticoagulation, and often in that situation, we're talking about kind of a switch to unfractionated heparin closer to delivery, and working with anesthesia to figure out what are their timing windows. Do we have the flexibility to allow, delivery as it comes, or do we need things where we need to plan? All of those questions are really important.
Yeah. And that's another great point, right? Is like, do you switch to unfractionated heparin or not? And so Venous Thromboembolism Network US did a survey of this pre-COVID. And it turned out it was about half and half. And it tends to be just divided by institution is what they gathered. And so I personally do not switch because I worry about a little bit of a depot effect with unfractionated heparin. I also think it's a lot of injections. My institution tends to be very lean towards induction a lot in these folks, in which case, like, well, if we're kind of going to plan it anyway, I don't see as much of the benefit. But again, half of hematologists do it differently. So do you switch to unfractionated heparin, Jori?
I was gonna say, yeah, it varies by institution, right? Our institution tends to switch, and we tend to non-induce. So that, again, because it gives us some more flexibility, maybe we have a little bit more time, but it's tough, right? So the monitoring of levels with unfractionated heparin, those injections are tough. So there may be, again, the patient where that's not an option, but that is kind of our standard practice at this time.
I'm pretty sure this was my last slide, so I think we can probably just go into questions. Oh, sorry. This is just from that publication that I mentioned that was also in JTH. We have a lot of publications from JTH today. This was a little table that we made about suggested delivery planning, consultation, content, making sure you're touching on all these things. There's also some tables in there about like the roles of different providers, right? So the roles of radiologists and vascular surgeons and pharmacists and all of these important members of the team. So I'm a little biased because, as you can say, I was the first author, but I encourage you to take a look. And then I think we can take questions.
So I do have a couple of questions that are related. You guys kind of mentioned for a moment that there are some nuances in terms of Lovenox dosing. So we have a few related questions about the Lovenox dosing, how you decide what weight to use. Do you cap the weight as the weight continues to increase? Do you say, no, there's a maximum here? How do you determine what the Lovenox dosing will be in a pregnant patient?
I feel like that's probably our pharmacist is probably the best one to offer this. I was taught to never cap. And so I don't cap. I don't think there's any data to support capping. I think it's to treat our discomfort, not to actually change the outcome. So I just 1 mg per kg BID, as high as we have to go, is my approach.
I will say, and I agree with you, I don't cap. And I do sometimes think about, particularly patients that struggle with the injections, the 1.5 mg per kg daily. There hasn't been kind of robust comparisons, but some anecdotal from folks who are, who use that frequently have not run into issues with it. So I do, particularly, twice daily injections is just awful. And then you're pregnant on top of it. So, and people who really struggle with that, if I think it'll help compliance and if it's really important to them, I do think about that as well.
If I can give you guys a few rapid fire questions from the from the audience, that would be great. D-dimer and HER2, do you use it? Yes or no?
Not usually.
No. Remember, HER2 as well was based on a very specific D-dimer assay, and so you got to know about your D-dimer at your institution. So I don't use it often. Okay.
Do you think about age at the time of an estrogen provoked clot? Like, does that factor into your decision making about duration and choice of therapy?
I don't know if it affects my decision making that much. I do, always have a conversation with patients that like our risk goes up with age. So whatever your risk is now, it's going to be higher later. But beyond that, I don't think it changes a ton.
Same.
Okay. What about depot? If someone maybe hasn't had a clot yet, but maybe they have family history or risk factors, when do you use and not use depot? Can you clarify that for us?
Yeah, so, I think it's a good option for a lot of people. So there's not, again, to Bethany's point, I mean, some of it is just shared decision making. If that's really the best option that works for people and they don't have a personal history, if that family history isn't that strong, it's not necessarily a reason not to use it. I think hopefully there are other options that might work for somebody if I'm really concerned about their risk. So that's a really soft answer, I guess.
I agree. And there's always stratification. And Depot actually has the highest rate of amenorrhea of any of our treatments, right? It's 55%, which is phenomenal, even higher than Mirena. So that's a point in its favor, I would say.
Okay, I'll have one more for you guys. What about assessing heavy menstrual bleeding at the beginning of anticoagulation? So you have someone with a new clot, maybe they already have a baseline history of heavy menstrual bleeding. How do you talk to them about that or risk assess that at the very beginning?
Yeah, so I think, again, that 7-2-1 rule is a helpful way to start and figure out where they are. And I think another thing that we haven't touched on is, I mean, look at their labs, and particularly if they're iron deficient. So another thing that I frequently find and kind of falls into this camp is the undertreatment of iron deficiency. So we have so many people who come in, have a new VTE, we're starting anticoagulation, and then their hemoglobin is already 9 with a ferritin of 3, and that person's about to bleed more. So I'm asking them about their menstrual bleeding. I'm checking their iron studies, even if they're not anemic. Remember, people can be iron deficient if they're not anemic, and remembering that your ferritin normal range in your lab is probably inaccurate. So a ferritin less than 50 in my mind is consistent with iron deficiency. And Bethany agrees. So that's part of my initial conversation. And then finding out, what are they currently doing? What have they done in the past about their menstrual bleeding? If they're not on an agent now, have they been on something in the past? And really making sure that there's a contingency plan in place to help that person so that when, so they know what to expect, because also that can be really scary when if no one has told you that you're going to have a lot of bleeding, all of a sudden you have a lot of bleeding. What if you get scared and you stop your blood thinner? So how much are they, quantifying the bleeding, assessing their iron status, making sure they understand what to expect, and then making sure there's kind of a contingency plan in place of, how are we going to control this when it likely happens?
I totally agree. And I would even say, for the contingency plan, in my institution, it can sometimes take a while to get into gyne. So I would say put in that gyne referral, at the same time as you put in that DOAC prescription, to try to get them in there before they've been suffering for too long with heavy bleeding.
Absolutely.
Because the best things I can't do. I can't pop in a Mirena. So I got to get my gyne colleagues involved.
Do we have any other pressing questions?
There's a whole bunch. What about dose reduction of DOACs for heavy menstrual bleeding in anticoagulated patients?
Yeah, so I think I mentioned I do dose reduction, but I'm hesitant to do that in that acute treatment period, right? So, those studies were designed after 6 months, and someone who's having a lot of bleeding, I think we feel that first 3 months is really the key time for acute thrombosis healing. So I will sometimes push it at 3 months if they need a dose reduction and they had a low risk VTE. I will consider that. So again, we're talking about going from apixaban 5 milligrams twice daily to apixaban 2.5 milligrams twice daily, or if you are on rivaroxaban, from 20 milligrams daily to 10. But oftentimes if they're on rivaroxaban, I'm trying to get them on apixaban anyway, just again, because of that data, we suggested that that's potentially worsening their menstrual bleeding as well.
And does obesity play into your decision to dose reduce that patient for the purpose of bleeding?
Bethany, what do you think about this?
That's a great question. So I don't tend to dose reduce. Again, it's an area of debate. I think, if somebody can go down to, at that 6 months point, I said, great, maybe it'll affect your heavy menstrual bleeding, maybe it won't. There was data, again, Saskia Middledorf's group does a ton of important work in this area where they compared Riva 20 versus 10 versus aspirin, and there was maybe a numerical decrease, but there wasn't really a meaningful decrease. And so in my practice, I don't tend to dose reduce. So I guess the answer is no, I don't change that based on obesity, but Jori, you do. So interested in what you think about that.
Yeah, I am more hesitant to dose reduce in someone who, is say greater than 120 kilograms, BMI over 40, or kind of those thresholds, where I do hesitate, just because I worry that those people were not necessarily as well represented in some of the trials that do suggest dose reduction can be performed. But I think it's a great point, Bethany, not relying on dose reduction alone as something to control menstrual bleeding, because it very well may not. So thank you for highlighting that.
And then a lot of people are asking about this, so maybe it will have to be our last one, but injection site for very pregnant patients, that gets tricky. So what do you guys recommend for your patients?
That's a great question. So full disclosure, I was a pregnant person on Lovenox. So I always say, like, there's usually always like a little bit of a love handle that you can get to that's not super stretched out. Or I have patients who sometimes do it in the thighs. Now making sure that that's actually, you know, a sub-Q injection and not an intramuscular injection. I think it's good to get our nurses involved in that conversation. But I would say those are kind of the two things I point at. And I just say, stay away from the belly button. It hurts and there's vessels there. Just stay away.
Thank you. Thank you all. I'm so sorry. I know we didn't get to all of the questions, but it is time. I just wanted to thank all of our guests again and share a couple of updates with everyone. Please join us next month for our webinar on June 11th, addressing the 2024 PAD guidelines. Dr. Jeff Barnes will be moderating, Dr. Herbert Aronow will be presenting, and then mark your calendars. We do have our 18th National Conference on Anticoagulation Therapy already scheduled for April 3rd through 5th, 2025 in Washington, D.C. We would love to see you all there. Thank you so much for joining us this afternoon. We will see you next month.